Okay, let's talk about abnormal vaginal discharge. It's one of the most common complaints you'll see in gynecology. But for students, figuring out what's normal and what's, well, not normal can be a real challenge. So today, we're going to build a super clear framework to help you tackle this topic with confidence. So let's just start with the most basic question. Is every single case of vaginal discharge a sign of disease? The answer is a definite no. And honestly, understanding why is the key to getting your diagnosis right.
So how in the world are we supposed to tell them apart? Well, the key is all about balance. To be able to spot what's abnormal, we first have to get a really solid understanding of the normal physiological baseline. So under normal conditions, vaginal fluid is usually going to be white and watery, and it won't have an odor. Now, microbiologically, the real heroes here are lactobacilli. These are the good bacteria. They produce lactic acid, which keeps the pH acidic, right around 4.0. And this acidity, it's like a crucial protective shield against pathogens. What's also really important is that in a normal sample, you will not find white or red blood cells. Their presence would be a big clue for inflammation or bleeding.
Now, what happens when there's simply more of this normal fluid? That brings us to our first key term, physiological leukorrhea.
Let's be really clear on this definition. Leukorrhea is strictly an excessive amount of otherwise normal vaginal discharge. It's not an infection. It's not a disease. It's just a physiological state.
This brings us to a super important high-yield rule that I want you to remember, the 3 nons. To be classified as leukorrhea, the discharge must be non-purulent, so no pus. It has to be non-offensive, meaning no bad smell, and it must be non-irritant, so it doesn't cause itching. If your patient has pus, a foul odor, or itching, you are dealing with pathology, not physiological leukorrhea. This is your key diagnostic filter. So when should you expect to see this kind of normal increase? Well, it's all about hormones, especially estrogen. You'll see it during puberty as estrogen levels start to rise, around ovulation when estrogen peaks, and definitely during pregnancy, which is a state of hyperestrogenism. Increased secretion during sexual excitement is also completely normal and physiological.
Excellent. Now that we've got our normal baseline established, let's build on it and create our framework for identifying true pathology.
Think of this flowchart as your mental map. As you can see, we classify the causes of abnormal discharge into 4 main groups. You've got non-infective, which we just covered as leukorrhea, and then the 3 pathological categories: infective, neoplastic, and the presence of a foreign body. Let's put them side by side just to make it crystal clear. This slide directly contrasts non-infective discharge or leukorrhea with infective discharge. And notice how the 3 nons are the complete opposite of the signs of infection, which is typically purulent, offensive, and irritant. This is the first and most important branch in your diagnostic thinking. Now, let's zoom in on the category you'll see most often, both in your exams and in the clinic, the infective causes. Okay, this table is pure high-yield gold. You really need to pay close attention to the buzzwords. For trichomonas, you're thinking frothy yellow discharge with itching. For monoleal vaginitis or candida, the classic description is curdy white discharge, kind of like cottage cheese, with intense itching. And for bacterial vaginosis, you've got to remember the gray-white, fishy odor, which, importantly, is often not itchy or non-pruritic.
And let's lock in this key clinical pearl. If a patient's main complaint is severe vulvar itching, that's pruritus vulvaea, your top 2 differentials should immediately be an infective vaginitis from either trichomonas or candida.
Okay, let's tackle a common pitfall. This next clinical scenario is one that often trips students up if they don't have these concepts clear in their head.
So, picture this. A pregnant patient comes to you, and she's concerned about an increase in white discharge. It's not itchy, and it doesn't have a bad odor. Your first instinct might be to think, infection. But is it vaginitis? Not necessarily. And this is where our whole discussion comes full circle. Remember that pregnancy is a state of hyperestrogenism, a primary cause of physiological leukorrhea. The fact that there's no itching and no odor, that should point you away from infection and towards a normal physiological change.
All right, let's bring it all together. Here are the most important high-yield points you absolutely must know for your exams.
You know, this quote from D.C. Dutta's textbook just perfectly summarizes the core concept. I want you to memorize this. Leukorrhea is an excessive normal vaginal discharge, non-purulent, non-offensive, and never causes pruritus. This definition will serve you so well. So, here are your key takeaways. Number 1, always differentiate physiological from pathological first. 2, use the 3 nons as your go-to tool for identifying leukorrhea. 3, you've got to associate the classic buzzwords, frothy, curdy, and fishy with their specific pathogens. And finally, remember that pruritus is a major red flag for an infection.
So if you remember only one thing from this whole explainer, make it this. Your first job is always to differentiate a physiological excess from the signs of pathology.
Here is a simple 2-step approach you can use in the clinic. Step 1. Ask about the 3 nons. Is the discharge purulent, offensive, or irritant? If yes, you're on a pathological track. If no, move to Step 2. Consider physiological leukorrhea, especially if the patient is in a high estrogen state like pregnancy or around ovulation. This simple framework will guide you to the right diagnosis.